Good morning, everybody. My name is Dr. Panna Shete, Assistant Professor from Patil College, Kolhapur. And today we'll be discussing about traction therapy used in physiotherapy. So, what are the aims? We are going to learn about traction therapy in this lecture. First is general principles of traction therapy, introduction to traction therapy, physiological and therapeutic effects, methods of application, indications and contraindications, precautions and danger. Now the learning outcomes will be general principles of traction therapy, physiological effects of traction therapy, methods of application, indications and contraindications, precautions and danger. Now let's go to general principles of traction. The first principle is the grip or hold on the patient's body must be adequate and secure. Provision for counter-traction must be made. There must be minimal friction on the cords and pulleys. The line and magnitude of the pull, once correctly established, must be maintained. There must be frequent checks on the apparatus and of the patient to ensure that the traction setup is functioning as planned. The patient is not suffering any injury as a result of the traction treatment. If you do not follow these principles in a correct way, in a proper manner, the purpose of treatment or the result which we want might not be achieved, or we might cause undue harm to the patient. So it is very important to follow these general principles of traction. Now let's go to the physiological effects of traction therapy for every segment. Effects on spinal movement. Then comes effects on bone, effects on ligaments, effects on disc, effects on articular facet joints, effects on muscular system and effects on nerves. Now we'll study each in particular. Effects on spinal movement. Traction therapy encourages movement of the spine both overall and between each individual joint segments. Now the amount of movement varies according to the position of the spine, amount of the force applied, the length of time the force is applied, and the separation is usually of 1 to 2 millimeter is being seen to be reported. Okay, any doubts in this so far? Okay, we'll go to the next slide. Effects on bone. We all be aware about the Wolff's law. This Wolff's law is applicable to the traction therapy also. Whenever what it states, the Wolff's law states that whenever mechanical load is applied to any tissues of the body, the tissues adapt to the load that can be compression, traction or shear or any other. So this principle applies to bone also. The traction helps in increasing the movement of the vertebral bodies and hence prevents bone weakness or reduction in bone density occurring due to spinal movement. When there is no movement in the bones or any bone in the body, the joints, bones tend to go for reduction in bone density and ultimately can lead to osteoporosis. So traction helps in movement and thus preventing your osteoporosis. Now effects on ligament. With rapid loading, the ligaments become stiff and resist the deforming force. But with slow loading, allows the ligaments to lengthen slowly, hence reducing the risk of injury. Whenever there is rapid loading of ligament, whenever there is rapid force, the ligaments tend to tear. But at the same time, when there is slow loading on the ligaments lengthen. And hence there is reduction in risk of injury. When any ligaments have shortened or contracted after injury, slow loading traction may help to restore their original length. Due to immobility and or after surgery, many times the ligaments they go for shortening and later they go for contraction. So to prevent these contractures and to maintain the optimal length of the ligaments, traction is helpful. And it also helps in activating the proprioceptors, which helps in reducing the pain. Effects on facet joint. Facet joints are seen is a small synovial joint present. Okay, this is the facet joint. It's a synovial joint present at the posterior aspect of the vertebra, this spine. This is a very common joint involved. It's helpful, the traction is helpful when there is problems with the facet joint motion. So the nerves passing through the facet joint can lead to nerve impingement. Loose bodies that get entrapped in the joints can cause pain. So traction helps in increasing the compression and helps in relieving the pain. Effects on muscles. Traction causes lengthening of the shortened muscles. Now, when there is lengthening of the shortened muscles, this leads to relaxation of the muscles and it reduces the pain. Thus, it helps to break the pain spasm, pain mechanism. Whenever there is pain, the patient tends to hold that part of the body stiff, and this increases the spasm and again increases the pain. So traction helps in lengthening of the shortened muscles and helps in breaking this pain spasm, pain cycle. Effects on nerves. This is very commonly seen symptom which is in which traction is very helpful. Pressure on the nerve roots produced by disc bulge, facet joint irritation, as we discussed in the prior slide. Bony spurs or narrow intervertebral foramen causes spinal pain and other neurological symptoms. One of the most common neurological symptoms we can see is paresthesia. It is very commonly seen in nerve root compressions. Continuous unrelieved pressure on the nerve root may lead to nerve root dysfunction, thus resulting into weakness and numbness to motor and sensory areas supplied by that nerve root. In such cases, traction is often helpful, relieving the pressure over these nerves and re-establishing the blood circulation and nutrition to that nerve so that the nerve can return to its normal conducting activity. Now let's go to methods of application. If you all have any doubts till now, you can please ask. Okay, let's move on to methods of application. There are two basic methods of application. One is manual traction and mechanical traction. The main difference is in manual traction, the therapist applies the traction by himself on the patient, and mechanical traction, there is use of electrical devices that causes the traction on the patient. Now in manual traction, let's see first in cervical, identifying the patient in supine or in sitting. Now here you can see the therapist cupping the hands under the occiput, here the occiput, and giving a mild traction. You can see here also bilaterally the patient or therapist is holding the patient and giving a upward pull or upward traction. This is a lumbar. The patient is lying with knee flexion and hip flexion. The therapist sits in front of the patient's knee, facing the patient's knee, cupping the hand under the calf and giving a pull this direction. Now let's see the advantages and disadvantages of manual traction. Advantages is no equipments are required, short setup time. Time is required is less. Like no, you don't have to arrange for the apparatus, the table, the parameters, everything. The patient comes and you can start with the therapy. Force can be finely graded. I know how much force I want, I can grade accordingly. Therapist present throughout the treatment to monitor. It can be applied briefly. It can also be used to check whether the patient can tolerate a mechanical traction. So before putting the patient on the mechanical traction, we can use manual traction to determine if longer application of traction can be tolerated by the patient. It can be used if patients do not tolerate being placed on halters or beds. Now let's see the disadvantages. Limited maximum traction force, probably not sufficient to distract the lumbar facet joint. Now this force, it depends on the strength of the therapist. The strength of the therapist might not be sufficient enough to distract the lumbar facet joint, especially in case of a hefty patient or a largely big patient. Amount of traction force cannot be easily replicated or specifically recorded. A therapist cannot give the same force the next day. He cannot replicate the force given on today, and he cannot replicate the same force the next day, neither can it be recorded. It cannot be applied for a prolonged period of time due to fatigue. Requires a skilled clinician to apply. Now these are the pictures of cervical traction. One is in supine and one is taken in sitting. So supine cervical traction with soft mandibular halter. This is the mandibular halter with approximately 20 to 30 degrees angle of flexion. You can see there is angle of flexion. This helps in maximizing separation of the intervertebral foramen disc spaces. This is in sitting with cervical spine in neutral. Now application of the cervical traction. First, we select the appropriate mechanical traction device, whether the patient is comfortable in sitting or in supine. Determine optimal patient position. Apply appropriate belt or halter. Connects the belt to the halter to the traction device. Set the appropriate traction parameters. Now select the appropriate mechanical traction device. Various devices are available for applying mechanical traction to the cervical spine in the clinic or home setting. The choice depends on the region of the body to be treated, the amount of force to be applied, it's whether static or intermittent, and the setting in which the treatment is going to be applied. Now the optimal position of the patient. When positioning the patient, try to achieve a comfortable position that allows muscle relaxation. If the patient is not comfortable in your given position, the muscles will not relax and the desired effect will not be achieved. The patient might go into more spasm and more pain. Okay, when positioning the patient, try to take a position that allows muscle relaxation while maximizing the separation between involved structures. The relative degree of flexion or extension of the spine during traction determines whether which surfaces are most effectively separated. Like for example, flexed position results in greater separation of the posterior structures, including the facet joints, intervertebral foramen, whereas neutral and extended position results in greater separation of the anterior structures, including the disc space. For the application of traction to the cervical spine, the patient can be in sitting or supine position. So 20 to 30 degrees of flexion, as I showed you in the previous picture, will help in relieving your posterior structures. And neutral, when the neck is in, spine is in neutral or an extended position, it helps in relieving or separating your anterior structures, including the disc space. Now, application of the appropriate belts or halters. A number of different cervical halters have been developed to maximize the patient comfort and avoid excessive pressure on the temporomandibular joints during the application of the cervical traction. There are soft fabric halters that apply pressure through both the mandibles and the occiput, and soft fabric halters that apply pressure only through the occiput. If the patient has some problems with his temporomandibular joint, then there are halters that apply pressure only through the occiput. The Saunders frictionless traction halter, which is solid and padded, is also designed to apply pressure only through the occiput. This is an example. Now, how do we connect it? Now, connect the belts or halter to the traction device. For cervical traction, all types of soft fabric halters are connected to the traction device by a rope and a spreader bar. Let me show you this. This picture here. This is a rope and this is a spreader bar. And the Saunders halter is connected directly to the traction device via rope. Then next we do is set the appropriate traction parameters. Select static or intermittent traction. For static traction, set the maximum traction force and total duration, traction duration. For intermittent traction, set the maximum and minimum traction force, hold and relax times, and the total traction duration. Let's come to mechanical lumbar traction. This is a mechanical lumbar traction unit. We have the settings for the hold relax time, traction time, and the force. This is a split table which you can see here, and the patient is lying with hip knee flexion on a small stool. This helps in reducing the lordosis and can give a better result. You can see the rope attached to the traction unit and pelvis belt. This is the split table which moves along with the pull of the traction. Here the patient is lying with hip knee flexion, ropes attached with the thoracic and pelvis belt for stabilization. These are the belts, traction belts. Now application. Select the appropriate mechanical traction device. It's similar to the cervical. Some things are different. Various devices are available for applying mechanical traction to the lumbar spine in clinic or home setting. Your choice depends on the amount of force to be applied, whether static or intermittent, and the setting in which the treatment is to be applied. Now determine optimal patient position. When positioning the patient, try to achieve a comfortable position that allows muscle relaxation, maximizing the separation between the involved structures. Same here, relative degree of flexion or extension of the spine during traction determines which surfaces are most effectively separated. The flexed position results in greater separation of the posterior structures, including the facet joint and intervertebral foramina, whereas neutral and extended position results in greater separation of the anterior structures. For the application of traction to the lumbar spine, the patient may be positioned prone or supine. In cervical we saw it was sitting or supine. Here it is prone or supine. Supine positioning is more commonly used. However, prone positioning may be advantageous if the patient does not tolerate flexion or being supine, or if the patient symptoms are reduced by extension. When you assess, if you see the patient symptoms are getting reduced by extension, then the desired position for that patient is in prone. Greater lumbar paraspinal muscle relaxation and less EMG activity have been also reported during traction in prone rather than supine position. Now, what are the advantages? Force and time well controlled of mechanical traction in general. Force and time well controlled, readily graded and replicable. Once applied, does not require the clinician to be present with the patient throughout the treatment. You can just come and keep checking on the patient. Electrical mechanical traction unit allows the application of static or intermittent traction. There is no static or intermittent traction or grading in manual therapy or manual traction. What are the disadvantages? It's expensive, time consuming to set up. You arrange the bells, see the position of the patient is not comfortable in supine, put him in prone, then arrange for the bells, then give him the knee flexion, arrange for the parameters. So it's basically time consuming as compared to manual traction. Lack of patient control or participation. Restriction by belts and halters poorly tolerated by some patients. We'll come to this, the conditions where we can see hold toleration. Mobilizes broad regions of the spine rather than individual spinal segment, potentially inducing hypermobility, normal or already joints which are hypermobile. So these are the parameters, general parameters which can be used for lumbar in initial and acute phase. The force used is 30 to 20 kgs. Hold relaxed time, we will use it in static, and the treatment time is 5 to 10 minutes. Joint distraction 22.5 kg or 50% of the body weight. Hold relax is 15 seconds by 15 seconds, hold and relax, and total traction time is 20 to 30 minutes. To decrease muscle spasm, the force applied is 25% of the body weight. Hold relax time is 5 seconds, hold and relax is 5 seconds. Total traction time is 20 to 30 minutes. For disc problems or to stretch soft tissues, we use 25% of the body weight. Hold time is 60 seconds and relax time is 20 seconds. Total traction time will remain 20 to 30 minutes. Now for cervical, its initial or acute phase, the force applied is 3 to 4 kgs, static, and traction time will remain 5 to 10 minutes. For joint distraction, we use 9 to 13 kgs or 7% of the patient's body weight. 15 seconds hold and 15 seconds relax time. Total time duration will be 20 to 30 minutes. To decrease muscle spasm, 5 to 7 kg of force, 5 seconds by 5 seconds hold and relax time, 20 to 30 minutes treatment time. For disc problems or to stretch soft tissues in cervical area, 5 to 7 kg force, 60 seconds hold and 20 seconds relax time, 20 to 30 minutes will be the total treatment duration. Moving to the next slide. Now, what are the indications for mechanical traction or traction? Disc bulge or herniation, which causes reduction in traction causes reduction in disc bulge or protrusion and thus reduces the compression on the spinal nerve roots. We have already seen this. Nerve root impingement because of the decompression, if the nerve is getting impinged in your vertebral foramen canal or in your facet joints, the loose bodies, traction helps in decompressing and relieving the pressure on the nerves and thus relieving the pain. Joint hypomobility, subacute joint inflammation and muscle spasm, causing the muscles to relax and hence reducing the muscle pain. As we read in the previous slide, which helps in breaking the pain spasm, pain cycle. Now, what are the contraindications for using retraction? Now, first is where motion is contraindicated for the patients. Traction should not be used if motion is contraindicated in the area to be affected. Example, with an unstable fracture in case of cord compression or shortly after any spinal surgery. Acute injury or inflammation. Acute inflammation may occur immediately after trauma or surgery or as a result of inflammatory diseases such as rheumatoid arthritis or osteoarthritis. Since intermittent or static traction may aggravate the acute inflammation or interfere with the healing of an acute injury, traction should not be applied under these conditions. Unstable or hypermobile joints. High force traction should not be used in areas of joint hypermobility or instability because it may further increase the mobility of that area. In any traction, it's always advised to start with a low force and then you can increase the force accordingly to the toleration of the patient. Peripheralization of symptoms. Peripheralization of symptoms is the pain or the symptoms radiating or moving further more peripherally. Traction should be discontinued or modified immediately if it causes peripheralization of symptoms, that is general progression of spinal symptoms from a central area to a peripheral area. It is indicative of worsening of the nerve function and increasing compression. So if the patient comes with a peripheralization of symptoms, that gives you an indication to either modify or stop the traction therapy. This can be happen either during the therapy or after few hours or the next day of the therapy. What are the precautions to be taken? Structural diseases or conditions affecting the spine like tumor, infection, rheumatoid arthritis, osteoporosis, prolonged systemic steroid use. And pressure of the belts may be hazardous or we cannot put the belt. For example, the most common is pregnancy, Patil hernia, vascular compromise and osteoporosis. Vascular compromise is when we put belt on the pelvic belt. It can cause pressure in the inguinal region and can cause insufficiency in the femoral artery. Displacement of annular fragment or medial disc protrusion. Traction, when there is medial disc protrusion, traction can aggravate the symptoms. It can push the medial disc more, compressing the nerves and symptoms might aggravate. Whenever there is medial disc protrusion, traction is not the choice of treatment. Severe pain fully relieved by traction. When the patient is completely suddenly relieved after traction, it can mean that there has been more damage to the nerve and thus the patient is no longer feeling the sense of pain. It does not mean that the patient is getting relieved by the symptom, because the traction is causing more harm to the nerve. Claustrophobia. Patient who cannot tolerate prone or supine position. Disorientation. TMJ joint problems. dentures. This is applicable for especially for cervical traction, TMJ and dentures. It was